Now we will move into the question and answer portion of the program, and Dr. Evidente will lead it. Dr. Evidente, please proceed.
Are you able to see my slides?
Yes.
Wonderful. Okay. Okay, thank you so much. Thank you again, Dr. Dashipur, for that wonderful presentation. We'll continue on with some more things that the audience actually submitted to me even before the webinar in connection to our theme today on cognitive impairment and dementia. Dr. Dashipur, touched on this, on the vascular risk factors and all that. And so one of the questions posted was, is there a relationship between high blood pressure and dementia? And the obvious answer is yes. So uncontrolled high blood pressure can lead to the so-called white matter changes or even frank strokes. And I'll make you focus on this MRI, which we have here. All this white stuff that you see here in the gray area of the brain, all of this white stuff is abnormal. Now, mind you, we accumulate some of this white stuff as you get older, but if you have the so-called vascular risk factors like diabetes, uncontrolled high blood pressure, obesity, high cholesterol, heart disease, and family history, and so on and so forth, you could accumulate more of this. And at some point, this may cause some issues, either Parkinsonism or dementia. And so when it comes to blood pressure, though, you have a history of blood pressure issues, what can you do to prevent yourself from developing dementia in the future? So the obvious answer is to control your blood pressure. In fact, they found out that if your blood pressure is high in midlife, and midlife is defined as, let's say, 45 to 55, and or if your blood pressure is too low in late life, so you're talking about 65 and above, those factors predispose to developing Alzheimer's disease. So really, if you have high blood pressure, the midlife is really where you have to focus. Lifestyle change, weight loss, take your blood pressure medicines, and so on and so forth. And the other thing that high blood pressure in midlife predisposes to is what's called vascular dementia. And again, Dr. Dashipur alluded to this. It's not Alzheimer's disease. It's not Parkinson's disease. It's just all this white matter changes that accumulate. And the more and more of this you have, the more cognitive impairment you have. And when your activities of daily living are now compromised, then you cross the line and now are diagnosed with the vascular dementia. So you can prevent that, by obviously modifying the so-called vascular risk factors. And mind you, can you have vascular dementia and vascular Parkinsonism on top of Parkinson's disease and Parkinson's disease MCR dementia? And the answer is yes. It's a double whammy. So if you have vascular risk factors, you have Parkinson's disease, then you have two things that favor you moving towards a direction of cognitive impairment and dementia along the road. And then finally, there are at least 3 trials that showed that if you control your blood pressure, especially in midlife and or early late life, chances are you will protect yourself against cognitive decline and dementia. Okay, Dr. Dashipur, any comments on this so far, or did I just echo what you just said earlier?
Yeah. So everything, as you said, I agree. However, I just want to emphasize the importance of also, which you mentioned, but emphasize about low blood pressure in my patients with Parkinson's disease. I think that's the area that we should look into it. When patients are running low blood pressure, a lot of times they need further adjustment of our hypertensive medications. Go back to primary care physician, tell them that, okay, maybe I don't need it anymore. Or there are medications like fludrocortisone, droxidopa, and midodrine that we can use to bring the blood pressure up, because low blood pressure not only can maybe cause some cognitive issues, can cause frequent falls, lightheadedness, lack of the motivation to move. So that's, I think, is very important.
And thank you for sharing that. And in fact, whenever I see patients in my office that get dizzy when they stand up, so-called orthostatic dizziness, and I take their blood pressure, and the systolic blood pressure drops by at least 20 points, or the diastolic drops at least 10 points. And many of my Parkinson's patients are on the dry side. They don't want to drink, enough fluids during the day because they don't want to go peeing, during the day or during the night. They're the ones that sometimes when their blood pressure drops, boy, they're also fuzzy-minded and confused. Yeah, thank you for sharing that. Okay, so next slide. What about blood sugar? Can blood sugar affect your cognitive ability? So I found this study, which is published in a very prominent diabetes journal in 2018. There were more than 5,000 participants. This was an aging study which was done in the UK. And what they did was they performed this cognitive test that Dr. Dashkapur, this screening test that Dr. Dashkapur alluded to every 2 years for 10 years. And also they monitored their hemoglobin A1C, which is a gauge of your sugar control over several weeks. And so they categorize them as either normal or pre-diabetes, and pre-diabetes being defined as a hemoglobin A1C of 5.7 to 6.4, or they have frank diabetes, meaning 6.5% or above. And what they found was, if you're pre-diabetic or if you're diabetic, chances are you have, and you do this cognitive test every 2 years for the next 10 years, chances are you have greater possibility of developing cognitive decline during that period. So the take-home message here is even the so-called pre-diabetes is not something to sneeze at. It's not something to minimize. It can do some damage. As neurologists tend to take this more seriously, many of our, I think, endocrinology colleagues are happy with the so-called pre-diabetes range, when in fact, when it comes to the nerves and the neurons and the brain cells, even pre-diabetes can perhaps, do some damage. Any thoughts on that?
No, thank you for sharing. So the only question, this study was on general population or?
Yeah, it's a general population, yeah.
Because I believe that, correct me if I'm wrong, but I don't remember it right now, but I believe that I saw the study that also was in Parkinson patients, that also in Parkinson patients who has diabetes, they have more chance of developing. I'm not sure that if it was like this prospective clinical trial, but they looked at patients with diabetes, they have a more chance of cognitive decline versus non-diabetes patients.
Yeah, I think I've also read those papers, and most of them were not actually longitudinal, follow-up studies.
That was observational.
Yeah, they were kind of comparing patients with diabetes with Parkinson's versus Parkinson's without diabetes, and you're absolutely right. These patients with diabetes have more, vascular pathologies in their brains, the so-called white matter changes, and the frequency of MCI and dementia was actually frequent, more higher in that population of patients with diabetes. Thank you for sharing that.
Sure.
Okay, moving forward. Okay, this is a touchy subject, alcohol. And so is there a relationship between alcohol and cognitive impairment? So we know for a fact that that intake of excessive alcohol is bad. Everybody will acknowledge that. I just want to introduce, a couple of things, which is, one is there's such a thing called alcohol dementia, which is just dementia because you just drink excessive alcohol. And there's also what's called alcohol-related Parkinsonism. So in other words, these patients with alcohol-related Parkinsonism, they act like they have Parkinson's, they have gait impairment, they may be ataxic or have balance issues, but lots of them have neuropathy as well, since alcohol abuse, especially chronic abuse, is associated with vitamin deficiency, especially the B complexes, and patients eventually develop neuropathy, which adds insult to injury. So many of these patients that appear Parkinsonian and are alcoholics don't actually have Parkinson's disease. And many of them are categorized as having alcohol-related Parkinsonism. And if you do DAT scans on these patients or dopamine scans, they're normal. You do a skin biopsy, which Dr. Dashkapur alluded to as well, for alpha-synuclein. You don't see alpha-synuclein in their skin biopsies because this is just alcohol-related Parkinsonism. So alcohol accelerates the shrinking of the brain. So for instance, here's the brain of a moderate drinker over many years in the left. And then in the right side, here's the brain of an alcoholic, a heavy drinker, and you see the obvious difference between the two. So that begs the question as to what is excessive alcohol. And again, if you read different journals, you may read on different amounts, but the favorite numbers I want to quote to my patients are 1.5 ounces of spirits every day is the daily cap, whatever those spirits are, or 4 to 5 ounces of wine per day. And it seems like there's a sex difference as well. Men tend to have a greater threshold for wine, for instance, or even spirits before the amount of alcohol becomes injurious. And the other thing that I want to share with you is that the alcohol with chronic use as well causes the part of the brain called the cerebellum, which is here in circle. So there's a control subject, which is an alcoholic, versus an alcoholic subject with chronic excessive alcohol intake. And you see the cerebellum really shrink. And the cerebellum you need for coordination and balance. So many of these alcoholics, even if they're not drunk anymore, they're walking like they're drunk because their balance centers, including this cerebellum, is affected and therefore affects their balance and even more so makes them appear like they're Parkinsonian. Any thoughts, Dr. Dashipur?
No, again, thank you for sharing. And I'm more rigid than you are regarding consumption of alcohol. And because I believe that alcohol, no matter what, we know that subside the nervous system. I know that that's why it improves the tremor, but the same way make you in a kind of relaxed mode, also decrease your attention. So if the patient has a touch of even cognitive impairment, it's definitely make it worse. I don't talk about its chronic effect, but I know that they make them worse cognitively at the moment when they are drinking. Plus, you probably noticed that there are a lot, depend on our genome. Some of us, we consume the alcohol more amount than others because of depend on the enzyme that we have in our liver to how metabolize it. But however, if you were able to be completely function well with whole bottle of wine. And when you are in your 70s, you realize that only with a 1 glass of wine, then you are not able. So when we get older, it seems that we cannot metabolize as when we were younger. So if my patient really want to take it, I said, okay, go ahead, but I'm not really big advocate for people like to hear that, 1 glass of wine is good for your heart and stuff. I really don't encourage that.
Okay, thank you. Thank you for sharing that. Okay, and this is a common one, Pervagen. Who hasn't heard of Pervagen, right? Everybody has heard of Pervagen. So should one be taking Pervagen because you read about this, you see it in the internet, people talking about it. It's in TV. It's highly publicized. So what is Pervagen? So it is a supplement that includes as its active ingredient this substance called apoechorin. And so it comes in different milligram strengths, so 10, 20, and 40. And this protein originally was collected from jellyfish from a particular area, but obviously can be seen in jellyfish in other areas. And the manufacturer claims that apoechorin can be useful and actually helps cognitive function. And the way they explain this is that apoechorin actually functions like a protein that is important for memory called calmodulin. So it's a calcium binding protein. And we know for a fact that without going to the details, one of the last things that happen before a cell dies is this accumulation of calcium because of abnormalities in the channels in the cell membrane and all that. And this excessive calcium in the brain or any cell for that matter leads to cell death. So if you bind the calcium, the idea is you foster survival of the cells. And this is also true for the memory cells, so to speak. The only problem with this is if you ingest it, okay, the so-called apoechorin, it is completely destroyed by your digestive enzymes and is transformed into amino acids. So So in essence, what this is introducing the amino acids in its precursor form. And that when they actually measure the amounts of amino acids that Pervagen supplies, it's actually lower than what you would be taking just having a normal diet, which is one of the things that Dr. Dastrober talked about. The diet is very important, especially a balanced one. So, hey, Dr. Dastrober, have you heard your patients talk to you about this?
Yeah, maybe they asked, but this is an area I told you that every time I speak with you, I learn something, and this is one of them. So I never actually investigated about Pervagen, but thank you for, again, educating me about that.
Yeah. I educated myself as well, since many of my patients, I actually learned from my patients because they challenge things like this. And especially if more than one patient has asked me, I kind of say, okay, it's time to kind of do my own research and see whether this has any value.
Is the make sense? Like if it was really effective, then why didn't do a clinical trial? Correct? Like they just
they did. Actually, they did.
And what did it show?
Well, they of course these are small trials, and most of them were uncontrolled, and there really wasn't much that. At least as a third party and a scientist reviewing their data, it doesn't reach the rigors that a drug approved by the FDA would have to undergo. Let's put it that way. Okay, next, what about a supplement which is very common called Huperzine A? And even I, know this supplement very well. Now, of all these supplements out there that are being marketed for dementia or MCI or whatnot, cognitive impairment, this is probably the one that comes closest to the drugs that are FDA approved. Now, why is that? Because number one, and Dr. Dastrober mentioned this, there's a number of substances or neurotransmitters which are deficient or excessive or abnormal in Alzheimer's or dementia. And one of these is acetylcholine. And in fact, the drugs that we use for Alzheimer's, like donepezil, which is Aricept, or rivastigmine, which is Exelon, or galantamine, which is Zorazidine, this work through an enzyme called cholinesterase, which increases acetylcholine levels. And Huperzine does influence this, the levels of acetylcholine, because it has this cholinesterase inhibitor property. Secondly, it also works very similar to another dementia drug for Alzheimer's called memantine, which is Namenda. So it is an antagonist. It is a glutamate antagonist, and anything that is excessive in glutamate usually is bad news. It leads to different disorders, including dementia of Alzheimer's type. In fact, even excessive glutamate has been implicated in more advanced Parkinson's dyskinesias, for instance. Is thought to be not just a dopaminergic, symptom, but also excessive glutamatergic influence. So this is the closest one, I would say, to all the drugs that are out there that are approved. It is also an antioxidant. It is a nootropic agent. So nootropes are not in vogue in the US. They're more in vogue in Europe. They're more in vogue in Asia. There's a lot of nootropic agents that are being used even for stroke or for hypoxia or Parkinson's or dementia and so on and so forth. And then the small early studies show that it may improve memory and possibly protect nerve cells in Alzheimer's. But if you do a systematic review, though, and see whether the quality of the evidence is good for its efficacy, the effect, in essence, what you will see is that the evidence for efficacy is quite low. Although it doesn't mean that there is no, anecdotal evidence for it, and that there is absolutely no evidence that it might work. It's just that the studies that were done on it were just not as rigorous as the studies that are done on FDA-approved drugs, and therefore the quality of evidence is not very good. And then, not surprisingly, the side effects are very similar to some of these Alzheimer's drugs that we prescribe. So very commonly, when I have a patient with dementia, mild dementia, or probably advanced MCI, and I talk to them about memantine or donepezil or rivastigmine, and they're so averse to this medication, especially after they read the side effects, and some patients are just so averse to any medicines for that matter. This is probably my next best thing that I would probably say, okay, evidence is weak, but it's very similar to the drugs that we prescribe for Alzheimer's disease. You buy it or you don't buy it, Dr. Dashipur?
No, I think the only concern is that if the patient's already on memantine or donepezil, then probably taking it together increases the risk of side effects.
Bingo. And in fact, that's exactly what some patients do experience. So again, it's more of an alternative, I would think. It's better than nothing, aside from, talking about, all those alternative non-pharmacologic, interventions that you talked about. But again, the evidence is weak, but the pharmacology seems to be very similar to the Alzheimer's drugs. Okay, let's move forward. What about Ginkobiloba? Okay, so many of us know Ginkobiloba, right? It's another drug you can buy very commonly, or should I say supplement you can buy commonly even in Amazon. So in fact, this is a drug, considered a drug in certain countries like Germany, where it is approved for many things like memory impairment, concentration disturbance, depression, dizziness, tinnitus, and headaches. And in fact, one of the things I use it for, off-label is actually tinnitus. I've had some success in using Ginkobiloba for tinnitus, especially in my Parkinson's patients. But there was a 2010 systematic review of 8 studies on Ginkobiloba in Alzheimer's. So the summary of these studies, minimum of 3 months, there were over 2,000 patients. They used doses from 120 to 240 milligrams. And then what they found was that the cognitive scores of patients on Ginkgo were better than that of placebo. So the conclusion was not definitive from this review, but possibly better. Possibly better. Again, it's better than nothing, possibly better. But FYI, it is approved for memory deficits in certain countries, as I said, like Germany. And then there was a Mayo Clinic review on this, and they say that maybe there's some evidence that it might modestly improve memory in healthy individuals, but that in general, most studies indicated it doesn't really improve memory, attention, or brain function that significantly. And again, there's, as with any supplement or drug for that matter, there are potential side effects. I think the biggest one is it thins out your blood. It's a blood thinner. It works very similar to your aspirin. It's an antiplatelet drug. And therefore, if you're Ginkgo biloba, don't be surprised if you bruise very easily, even with minor trauma. And maybe you should be careful when you take this supplement, especially when you're taking other blood thinners for whatever indication. Have your patients talked to you about Ginkgo at all?
Yeah, so because Ginkgo is actually more around like it than compared to other compounds that you mentioned. But yeah, always concerned, especially in our patient, you and I, is a concern is that majority of our patients already on blood thinner or anticoagulant and for atrial fibrillation, etc. And they really cannot even tolerate. So that because as you said, the concern about Ginkgo always was like a bleeding tendencies.
Sure.
So which is the high risk for our patients with a risk of fall. Yeah.
Okay, next. What about vitamin E? So, in the past, I've talked about vitamin E in Parkinson's because there was much hullabaloo about vitamin E, especially in combination with coenzyme Q. And in the past, when I was a fellow, and maybe Dr. Dashipur remember this as well, they used to market, high-dose vitamin E with high-dose CoQ, and it was so expensive, right? And at the end of the day, that study showed that it was not neuroprotective, that it wasn't delaying, the progression of the disease. So everybody's, finally abandoned using high doses of vitamin E or CoQ. But what about for memory or MCR dementia? So there was a 2017 Cochrane systematic review of all the important studies done on vitamin E, and they showed that there was no evidence that vitamin E prevents progression of MCI to dementia. Also, if you already have MCI or if you already have dementia from Alzheimer's and you take vitamin E, there was also no evidence that it improves cognitive function in those that are already in that state of MCR dementia. And then there's one single study that showed that maybe it may slow down the functional decline in Alzheimer's disease. But again, that's just one study. But no doubt in terms of being a preventative for Alzheimer's disease. And then I talked a while ago about the study that studied it for prevention of Parkinson. It's probably not very useful. So it's a good antioxidant overall, but it probably doesn't have much effect on cognitive impairment as well as Parkinson's. Any thoughts?
No, like you said, I remember that I think the result came out around 2007, 2006, 2007, when was a PSG trial.
Sure.
A combination of quantum Q, and then also vitamin E. That there was a lot of faith on it. Unfortunately, the result was negative again, correct?
Exactly. So everybody stopped taking that combination, which we were prescribing, or should I say advocating for a while. Now, curcumin or turmeric, we discussed this also with the previous webinar when we talked about Parkinson's. It's an anti-inflammatory substance, highly antioxidant. This time, I'm going to present, or should I say, just say that there is some evidence that it may affect the amyloid aggregation in Alzheimer's. So Dr. Dashtipur talked about the abnormal proteins that accumulate in some of these neurodegenerative disorders. Amyloid is to Alzheimer's, and so is tau, as is alpha-synuclein is to Parkinson's. So this may affect the aggregation of amyloid in Alzheimer's disease. And in fact, and I'm not sure whether this is directly related to their diet, but the frequency of Alzheimer's disease is much less in the East Indian population, where their diet is routinely including turmeric or curcumin. However, in a 2016 randomized, placebo-controlled trial, so 96 cognitively healthy older adults, they took curcumin over 12 months. There was really limited influence in cognitive function, mood, or general quality of life. So the question is, whether you really have to be on this all your life or decades. It's like the lifestyle change that Dr. Dashtipur just mentioned, rather than just take it for a short period and then you don't see anything, then you give up. But I think just having this in your diet, being an anti-inflammatory supplement, it certainly helps some of my patients with arthritic conditions. It's probably a harmless thing, to incorporate. Have you talked to your patients about this, or anyone asked you about this so far for curcumin?
They haven't asked me, but I'm Iranian, and all of our foods has turmeric.
Yeah, there you go.
I personally, whenever I make fish, I use it with turmeric even, and I even give turmeric to my dog. And when I give it out, put a little turmeric on it. So yeah, it doesn't hurt. And
you must have a very, very intelligent household then, huh? Including your dog. All intelligent, nobody's going to develop Alzheimer's. Excellent. Okay. What about the B vitamins? So Dr. Dashtipur talked about, vitamin deficiencies as being predisposing things to dementia and cognitive impairment, especially long-term. But these are also the reversible causes of so-called subjective cognitive impairment, or so-called pseudo-dementia. Pseudo-dementia means you're not demented. There's just something that's causing it, whether it be a lack of this or lack of that, or a medication, or blah, 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 or COVID. So there was a 2018 Cochrane systematic review. So 5 trials involving more than 800 individuals. And they found that there was no evidence for a beneficial effect of the B vitamins if you take them for 6 to 24 months. Although there was one study that showed that there was a reduced rate of brain shrinking or atrophy in patients taking vitamin B. There was also one study which showed that it may be beneficial on episodic memory. So this is the kind of memory that has to do with events in your life, like your graduation or your first trip to Europe, or you won the lottery. That's called episodic memory, that leave an impression on you. And so there's one study that seems to show that it's actually helpful for that. And then Also, as a follow-up to that, what about vitamin D? We know for a fact that vitamin D deficiency is more common, or should I say, has a higher frequency in patients with both Parkinson's disease and Alzheimer's disease. So it's both a predisposing factor and also very common in Parkinson's who are already diagnosed with Parkinson's. About 55% of them are vitamin D deficient, including Arizona, Dr. Dashipur. Believe it or not, in hot, sunny Arizona, there is an epidemic of vitamin D deficiency. And I think the main reason for that is because we just put lots and lots of sunscreen, and we don't expose ourselves to the sun, especially during the summer. So vitamin D deficiency seems to be more common. And so it is associated with more falls, more sleep issues, more depression, more anxiety, and more cognitive impairment if you're vitamin D deficient and have Parkinson's. And then in one study of ages 65 or more, if your vitamin D is less than 20, and the normal range is usually 30 and above, most of us want it in the 40s or 50s, somewhere in the mid range. But if your level is less than 20, you have a 53% higher risk of dementia and 70% higher risk of Alzheimer's disease. Now, if it is extremely low, though, so 10 or less, so these are the critically low levels. And these are the levels where your primary care will get so excited and probably say, you need high doses of vitamin D, 50,000 units every week for several weeks until this goes out. Okay, so that extremely low vitamin D, 10 or less, 125% higher risk of dementia and 120% higher risk of Alzheimer's disease. So this is probably one of the vitamins that I would want to monitor in my Parkinson's patients, even if they're here in Arizona and exposed to the sun. Any thoughts on vitamin D?
I'm not great, excited about vitamin D. The reason I'm saying that I don't like when we don't know causality. So these are something that we just found by accident or in epidemiological studies that, oh, low vitamin D now, because when you don't know the mechanism, that means that you are just fishing for the data. And then, okay, so I have patients with Parkinson's disease, they have low vitamin D. Doesn't mean that if you add vitamin D, they get better or prevent it. That one Correct. Explanation is that whatever causing Parkinson's disease is possibly sharing something common with the low vitamin deficiency. Very easy explanation can be like genetically. Maybe Parkinson's disease happened for the patient that they have genetically, they're running with low vitamin D, or environmentally. So yeah, I'm not in great a fan of when we look at at the epidemiological studies and look into it, okay, what is low? Because as you know, vitamin D got in the center of attention of all disease state, Parkinson's disease, Alzheimer's, multiple sclerosis. So as I said, it's good to monitor regularly primary care physician to check that, because low vitamin D can be is not good for health and then also for the bone health. But I'm not a believer of necessarily low vitamin means that then we supplement of vitamin D, you can control the symptoms or basically affect the outcome of the disease like a cognitive impairment. I agree.
That's
my opinion.
Yeah, I completely agree. If at all, maybe vitamin D, given that is tied up with the calcium levels. Many of my patients with vitamin D deficiency are also calcium deficient, and therefore many of these patients have osteoporosis. And so in our Parkinson's population, we know that they already have accelerated osteoporosis to start with. And so last thing you want is a patient with balance issues and falls and then has osteoporosis and a calcium deficiency in vitamin D. So I think in my elderly patients that are more prone to falling, I'm always more just cognizant of, okay, have we checked your vitamin D? Are your calcium's good? Have you had a bone scan recently and see whether you have osteoporosis or not? Okay. I think we have time for one more. What about virgin coconut oil? So virgin coconut oil comprises mainly of the so-called medium-chain fatty acids. So these medium-chain fatty acids can be converted to ketones, and ketones can be alternative fuel to the brain and your other cells. So there is some evidence that there is a relative insulin deficiency or resistance of the cells in the brain, and you need insulin for the glucose to enter the cells in the brain and be utilized. Glucose is the fuel for your cells. And so if you have this insulin resistance and the glucose is just around the cells but cannot enter them, then the cells get deprived of glucose or energy, and therefore they die. And that is one of the reasons or thinking behind why patients with with dementia have some relative glucose deficiency inside the cell. So the alternative to glucose not being able to enter are ketones. And this is where virgin coconut oil comes in. So there was a small clinical trial, 40 ml per day of extra virgin coconut oil, Alzheimer's disease versus control. And it wasn't a small trial, but it showed that there was some improvement in cognitive scores, especially in women, especially in more severe patients. Although a large clinical trial for Alzheimer's disease didn't show any benefit. So I'm not sure whether this has any potential at this point, but it's one of the things that's being explored even more so in certain parts of the world where coconut is very abundant in the tropical areas. But there's one thing that it's good for, constipation. I found out that many of my patients are constipated. At the very least, if they take virgin coconut oil, have improvement of their constipation. Okay, and lastly, I think, or maybe I'll talk about this. This is more interesting. Coffee for memory. So what they found was, a systematic review that caffeine may actually facilitate passive learning, not the active learning. Passive learning means you're just listening or reading a book. It also improves your working memory or your so-called short-term memory. I call it the temporary sticky notes in your brain. It improves alertness. So if you're kind of sleepy, medicines make you sleepy, you have sleep apnea, lack of sleep, this is where coffee probably has some role. It has no effect on long-term memory. It may prevent cognitive decline in normal elderly women. At least there's some evidence for that. Although there's an MCI study that showed that possibly those that took coffee, or should I say those that did not progress to dementia, had twice the levels of caffeine in their blood in comparison to those MCI patients that progressed to dementia. And then is it the coffee beans or is it the caffeine? So what they found was that regular caffeinated coffee seems to be better than decaf. And then Dr. Dashboard touched on this, adenosine A2 receptors. This actually co-localized in the striatum, which is what is involved in Parkinson's, and it actually enhances the dopamine receptor. So it acts like a chaperone, so to speak, a companion substance that helps stimulate the dopamine receptors. And then there was a study that on normal aging, that 3 to 5 cups of coffee daily during midlife may actually reduce the risk of dementia by 65% in later life. But again, too much of a good thing is bad. So whereas another study showed that if you take 6 or more cups per day, you actually will increase your risk for dementia, heart disease, strokes, or possibly even shrinking of the brain. You drink coffee, Kash?
Actually, yeah, a lot. I have to slow it down. Right. Now I realize that I have to go down.
How many cups do you drink?
I do few cups, but they have like a two or three shot of espresso in it. So
there you go. There you go.
Yeah,
no doubt. Whenever many of my patients, especially my elderly patients that are a little bit sleepy, when I give them a little bit of caffeine, I think it's the best way to perk them up, and it also improves their concentration and their alertness and ability to learn things. Okay, I think that is all the time that we have. We have to wind down. I want to thank our guest again, Dr. Dastuper, for this wonderful
Thank you.
We really learned a lot, and thank you for having this exchange with me and sharing your thoughts and your valuable insights on cognitive issues for Parkinson's and dementia patients. And then I hope we'll be able to have a chance again in the future to invite you for future webinars.
Anytime. Thank you for having me.